Hi everyone, welcome to the SBHC coordinators meeting. We are going to give folks another minute or two to join and then get started. Maybe as we give people another minute to join, I'll do a quick sound check. Can everyone hear me okay? Can you give me like a thumbs up or some other Zoom fancy reaction? Awesome. Thanks so much. Okay. Maybe we will go ahead and get started. It's 101 and people can kind of keep filtering in as we go. So hi everyone, I'm Kate O'Donnell. I'm the interim team lead for the State School-Based Health Center program. Thanks for joining us for our spring coordinators meeting. We have a very full agenda, as you can see here. So we're gonna try and keep on top of time and to make sure that we get through everything. We're going to start off with a snapshot from Sarah Nipper, our school health epidemiologist, to talk about Oregon Healthy Teens data. We have some updates from the State Program Office team after that. Then we'll hear from the School-Based Health Alliance. We'll take a break around 2 o'clock. And then the second half of the meeting, we are very excited about hearing from you all in the field about all the things that you're doing and the great work that's been happening. And then we'll close. We'll try and shoot for 2:55 to close and some final announcements before we wrap up. So before we jump into that and before I hand it off to Sarah, I just wanted to just say a quick word of thanks and appreciation for all of you. I have to say, like, we have been hearing about the wonderful work you all have been doing despite COVID, despite all of the things over the last year and a couple months, and are just really inspired and moved by how creative and resourceful you all have been, and just all the wonderful things that you're doing to support the communities you work with and the young people that you work with. I have this artwork on here that's a friend of mine's sister made this, and I've been kind of returning to it throughout the pandemic. It says, "Crisis expands our imaginations around what is possible." And I really have felt like talking to you all that you all are living that every day. Like, you are seeing this crisis and responding to it in such amazing, creative ways and thinking outside the box about what school health is, what adolescent health is, what the work we do could be. And so just wanted to ground our meeting today in appreciation for you all. And again, I'm really excited to be able to spend the last half of our meeting hearing about some of those really exciting things that you all are doing. So just appreciating you and thanking you for all the great work that you're doing. So with that, I am going to pivot and hand it over to Sarah to talk about our adolescent health snapshot.
Yeah, thanks, Kate. Hi, everybody. I'm Sarah Nipper. I am the epidemiologist with our adolescent and school health unit. And I am going to be spending about 20 minutes here. Just for those of you who have been with the school-based health centers for a while, we have done this presentation before, but essentially we wanted to give an update on some of the data indicators for the adolescent population in Oregon using our Oregon Healthy Teens data. Next slide, please. So Oregon Healthy Teens survey is a survey that has been conducted in odd years up through 2019. It is a survey of 8th and 11th graders, and it surveys a whole bunch of health-related topics and mental health topics. We've recently transitioned to the student health survey, which is 6th, 8th, and 11th grades, and that was fielded over the course of 2020 and 2021. The data that I'm presenting to you here does not yet have that student health survey data in it. We are very excited that will come out in the summer, but this is just an update with some trends, including our 2019 OHT data. Next slide. So the goals of the snapshot, this was something that West Rivers, who used to be with our program, designed a few years ago. And we really wanted to be able to present data to acknowledge and present information on youth health focused on a framework with 3 S's, so strengths, systems, and then survival. And so I'll be presenting a subset of some of these data points in each of these areas today. Just to give you a little bit of context for the population in Oregon, it's about 750,000 adolescents defined 10 to 24. Fewer than 2/3 are white, non-Hispanic. The adolescent population is actually significantly more racially and ethnically diverse than working age adults and seniors. And about 8% of adolescents in Oregon have a disability. So I'm gonna pivot into the framework now. So we're gonna start out with some data points related to adolescent strengths. So we have this positive youth development benchmark in Oregon, which is trying to capture youth strengths, and I'll present the benchmark later, but some of these questions are components of the benchmark. So we measure self-efficacy, so students who believe that they can succeed with effort. This has remained pretty flat into 2019. It's a pretty high percentage of our youth, both at the 8th and 11th grade level. Another component of the PYD benchmark, also related to self-efficacy, is students who believe in their ability to work out their problems. And this, went down a little bit from 15 to 17 and remained pretty flat, but still, a little more than 3/4 of our youth, do believe in their own ability to work out their problems. And then another component of the benchmark, which is extremely related to the work that you all do, is students who say there's an adult at school who cares about them. And this is a measure that we're actually, we saw a little bit of an increase in 2019. And I'm sure for some of these youth, that caring adult is you or somebody who works in your clinic. We asked youth about the last time they had a checkup or a doctor's visit that wasn't for illness or injury, and this has also been ticking up gradually over the last several iterations. So we're up to about 2/3 of our youth, which is great. And now I'm going to move into some of the systems data points that kind of capture maybe the context that youth are situated in a little bit more. So we have a lot of, or not a lot, we have a few questions on bullying. And this was youth who said they'd been bullied at school in the past 30 days for any reason. And so this is, been really pretty flat the last 3 years. And is much lower. You see in the 11th grade, the orange bar, about 20% of youth versus 30% of the 8th graders. And then we have some breakdowns here by some of the demographics. So unsurprisingly, when we break this out by gender identity, we see that youth who identify as female are more likely to say they've been bullied than those who are male. And then youth who said they are transgender or something else have significantly higher rates of being bullied, especially at the 8th grade level. So, that's something that is really important for us to pay attention to as we're trying to, serve our kids with more equity, and just pay attention to what are these factors that might be driving their school and mental health experiences. Again, when we look at it by sexual orientation, you can see some pretty significant differences here. 8th graders who identify as lesbian or gay had much higher rates of reported bullying than any other group of youth. But generally speaking, bullying rates are higher, much higher among non-heterosexual youth. So bisexual, kids who said something else, lesbian, gay, were much, much higher than those who said, straight or heterosexual. And again, much higher across the board in 8th grade versus 11th grade. Pivoting a little bit to food insecurity and thinking about the, the food systems and systems of poverty that kids might be in. This was youth who reported food insecurity in the last 12 months. And in 2019, it was down a little bit, which is great. This is a question that we also included on the 2020 Student Health Survey. With all of these, it'll be really interesting to see, given the pandemic, what indicators like this are looking like for youth. But at least in 2019, it had gone down a bit, although we still have a pretty substantial portion of youth who've said they have experienced food insecurity. Well, again, when we look at this by sexual orientation, we see higher rates among, non-heterosexual youth, so gay or lesbian, bisexual, something else. And in contrast to the bullying indicator, the 11th graders tend to have a little bit higher rate of reporting food insecurity than the 8th graders, for most of these subpopulations. And then just by gender identity, again, not much difference between males and females, but when we're looking at youth who identify as transgender or something else, the rates of reported food insecurity are really quite high. I mean, you can see that last orange bar, 30% of 11th graders who identified as something else in their gender identity said they had experienced food insecurity in the last 12 months, which is, extraordinarily high. And then one more breakdown here by disability. This one, I think we are, in the past iterations of our snapshot, we haven't done as much with breaking down by kids with a disability, but we can really see there's a lot of disparities here. So kids with disability, significantly more likely to experience food insecurity than those without. And lastly, we're going to move on to the survival portion of the data points that we have here today. So absenteeism, kids are reporting that they skipped school because it felt unsafe to them in the past 30 days. Cece, I'll get to your question in just one second. And this is going up a little bit. So if you compare kind of these trends over time, we see 2013 for 11th graders, it was 4%, and 2019, it's 8%. That's still pretty small, but that's a doubling of the rate. So that is a small trend. So Ceci, I'm looking, no, I didn't say 80% has some form of disability. 8%, yes, that's right, 8%. So vaping, this is something that, I think especially pre-pandemic, but I'm still to some degree was on a lot of folks' minds. We can see that, in 2013, this was hardly a thing at all, and has really grown, especially at the 11th grade level, up to 2019, where almost a quarter of students said that they had vaped in the last 30 days. Marijuana use, on the other hand, has been quite flat and maybe even a tiny bit down among 8th grades, but it's really holding steady at around 1 in 10, 1 in 11 8th graders, and about 1 in 5 11th graders have said they've used marijuana in the past 30 days. Around mental health, obviously this is something that we'll be very interested in seeing when we get our data from the Student Health Survey, which will be coming out this summer. But for the data that we have here, youth saying that they had exhibited depressive symptoms. This is a typo, actually. It should be the last 30 days, not the last year. So youth saying that they've experienced depressive symptoms in the last 30 days is going up, and especially that 11th grade level, moving up from 27% back in 2013 up to 36% in 2019. And then youth who said they've seriously considered suicide, about 1 in 5 of both 8th and 11th graders did report that they had considered suicide seriously in the past year, and another one that we'll be keeping our eye on with the new data coming out this summer. When we look at suicidal ideation by race and ethnicity, we see a lot of differences. And so you can look at this and see that the highest rates of suicidal ideation were among our youth who identified as Native American, multiracial, or some other race. Those were all above 20%. And then the lowest rates among youth who identify as Middle Eastern or North African at 8%. And everybody else kind of, in between 15 and 20%, but definitely some racial and ethnic disparities here in suicidal ideation. And then by gender identity, again, we see our transgender and gender nonconforming youth at much higher risk for suicidal ideation than youth who identify as female and male, and even there we see female youth with significantly higher rates of suicidal ideation than males. So this is definitely an area where there's quite a relationship between gender identity and mental health risks, as well as some of the other pieces that I've highlighted already. And then by sexual orientation, again, we see youth who identify as gay or lesbian or bisexual having significantly higher rates, especially at that 8th grade level, of having seriously considered suicide in the past year. And then I had brought up in the beginning our PYD benchmark. And so this is something we've had around since 2005. Oregon's really been a leader in this regard. But essentially we have these 6 questions. We combine them together, and we've established sort of a benchmark of, if you take all of these together and students have to answer a certain level on each question, can we sort of capture kids who are sort of hitting a certain level of positive youth development within the state? And so these are the 6 questions that make up the benchmark. And our PYD benchmark, they have to respond positively to either 5 or 6 out of the 6. And you can see that it's really been dropping over the years. And so, that's obviously not something we want to see. I showed you data earlier on that caring adult. I have an adult at school that really cares about me. That is one that is moving in the positive, in the positive direction, which is great. But some of the other pieces here are trending flat or downwards, which is bringing the whole benchmark down. The PYD benchmark by gender identity, huge disparities here. Youth who are transgender or gender nonconforming have about half the rates of meeting the benchmark as male youth, and female youth are substantially below their male counterparts as well. And then if, again, we look at it by disability, same thing. We see a lot of disparities here among kids who have a disability, and they're meeting the benchmark. And some of that could be related to, there's a physical health measure as part of the benchmark, but certainly there are other pieces that are driving this big disparity here. And then lastly, I'm just going to go through a couple of slides related to youth sexual health, because obviously, again, relevant to the work that you all are doing. The rate of youth who've had sex in the past 3 months is pretty flat. So about 30% of our 11th graders and around 5% of our 8th graders. We had a new question in 2019 about health education, whether they had been taught to use a condom to prevent pregnancy or STDs, including HIV, and then whether they'd been taught about how to use birth control methods or where to get birth control. And so, you know, at the 11th grade level, it's fairly high. And at the 8th grade level, you know, we would expect that these things should be being taught. And you can see there's quite a drop off, especially when it comes to birth control. We have a little bit of our immunization data here on HPV immunizations and who's completed, you know, females in blue, males in orange. And the great news is that our rates are going up, and especially you can see males, you know, down there at 6% in 2013 and almost caught up with females. And so the trends here, although there's a lot more work to be done, the trends here look really positive. Contraceptive use. You know, who's using contraceptive, what types of contraception they used among sexually active. And you can see broken down by highly effective, moderately effective, and less effective. Youth could choose more than one, but a lot of youth are choosing, you know, sort of a less effective method when it comes to STI prevention. Sexual and physical dating violence. This is a question that's just asked on the 11th grade survey. And those bottom two bars, the were forced to have sex or experience physical dating violence in the past 12 months. These are really flat, around 5%. And then the top, that light blue bar of 11th graders who were reported they felt pressured to have sex in the past 12 months. That one did tick up a little bit in 2019, up to 14%. And here you can see that broken down by gender identity, much higher among females as well as transgender and non-conforming youth, gender non-conforming youth, excuse me. And then lastly, just wanted to, you know, reflect on our teen pregnancy rate, which, you know, you all probably know that Oregon has seen one of the biggest drops in teen pregnancy rate of any state in the country over the last, you know, 15 to 20 years. So here we can see 2009 through 2018, you know, it's gone down quite significantly, down to below 20 pregnancies per 1,000 females. And that is it. And I think I have 2 minutes if there's any questions about the data, but you'll also get these slides, so you'll have them for reference.
Thanks, Sarah. Do folks have questions? You can type them in the chat box or just feel free to unmute yourself. It's a lot of data there, a lot to think on. So feel free to ask questions if you have them.
The reason for the decreased pregnancy rate, question from Trisha. Yeah, Trisha, it's something we've seen pretty universally, and certainly we've seen a big shift in Oregon and a lot of places away from abstinence-only education to comprehensive sex education, and we've seen more emphasis on availability of birth control, you know, now recommending LARCs as a method that's appropriate for adolescents. You know, there's been reductions in the poverty rate. So I think there's both sort of specific sexual health related reasons as well as like some bigger contextual pieces around poverty and access to care, and, you know, the uninsurance rate among youth like dropping really, really low.
So in the interest of time, I'm unfortunately going to have to move us on. If you have questions, feel free to reach out to us about any of this. And I mean, obviously we'll have to have Sarah or someone else back to talk us through the new data when it becomes available. I feel like it is, as Sarah mentioned a couple of times, this does paint a picture of like where we were at before we entered into the pandemic, and just so many questions about, you know, what the data will tell us about what happened during the pandemic. So Thank you so much for sharing this update with us, Sarah. And as Sarah said, we'll send out the slides so you can look at the data, and then we'll also have a recording posted on our website. So with that, I'm going to pivot to state updates. We have some important updates to share from our office, and so I want to make sure we get through those and have time for questions. So Rosalind, I will turn it over to you.
Hi everyone, I'm Rosalind Liu. I'm the Adolescent and School Health Interim Manager. So I like to give an update to everyone about our team so you can all understand what capacity we're functioning at when you're looking for assistance or the work that we get out, and just so you're aware who's on the team. So I've been in the interim position since November, and Kate has graciously stepped in to help us out. Her time with us ends at the end of June, so that will be one loss to our program again and again. As I tell Kate, it's like a tease for us. But I'm happy to have any time that she has given us, so it's been great. But she will be leaving at the end of June, so we'll have a little bit of gap there, and I will be stepping back in. I will be doing both roles again, and really trying to support the team, and then we'll be moving on from there. And then we have the vacant systems development specialist position, which has been the position in the past that has supported planning grants, technical assistance, some of the work around certification standards development. So I'm just about ready to put that out to be posted for hire. That position will be changed a little bit in that it'll be focused on school health programming, and not just school-based health center support, but our school nursing pilot program, which we have some funding for and developing. And then Karen and Rebecca still doing all the great work as our public health nurses. Kavita, our research analyst, just came back from maternity leave, and so as she's transitioning back with her new baby at home, she'll be working part-time, so limited hours. Kavita has historically focused on the fact sheets, kind of supporting our nurses with their data. So Loretta's been picking up a lot of that since Kavita's back, and still as Kavita's transitioning back. And then Sarah's doing some work with another office as part of OHA, and so she's kind of part-time with us, and then part-time with another office doing some also great health economist work. And so we're a little bit down on our data team. So as we try so hard to support you all with our data fact sheets and all the data reports that get out, just a little bit of patience, and everything may not look as pretty as it has in the past. And I think I've said this before. But if there's something specific you need or something you're looking for, the best thing to do is just reach out to us and contact our program email, and someone will get back to you, and we'll try to do the best we can in supporting you all. Funding. So at this point, we're in the process of the legislative session, and as you all know, we don't have a final budget going into next biennium, which starts July 1, 2021, until the legislature convenes, and then there's an adopted budget. At this point, everything seems pretty good, and we're predicting a stable funding budget, and so you will see that your contracts are starting to go out, and Kate's going to talk a little bit about that. And so we're working with a flat fund going forward. And again, we won't know our final budget until the legislature convenes. And so if there are any changes to funding, let's say we get more money, or if we have to take a reduction, which we typically would probably know about at this point, amendments will go out. But we're feeling pretty confident with a stable funding. Kate. But I did want to mention, and I'm sure the Oregon School-Based Health Alliance will talk a little bit about this. There is one big bill in play, House Bill 2591, which could bring some extra funding into our state program office. It's focused on supporting some new school health service models and also expanding our planning grants. So there's the possibility for 10 planning grants for new school-based health centers or school nursing programs, 3 mobile clinics, and 3 telehealth pilots. So right now it's passed through committees, or it's sitting in the Ways and Means Committee, and Ways and Means pretty much just sits there and tries to figure out how to balance their checkbooks. So we're just kind of waiting on that. And then we'll see. And again, like, we won't really know until we get closer to the end of session. Any questions for me around the funding piece? Nothing too exciting or drastic, which is probably good for us right now. I'll turn it over to Kate to talk about contracts.
Great, thanks, Rosalind. So just really quickly, I think we mentioned at our last meeting that we would be going through the process of asking the local public health authorities if they wanted to retain or give up the contracts for SBHC funding. So we did go through that process, and we surveyed all the local public health authorities and asked what their preferences would be. And surprise, surprise, no one wanted to change their contracting relationships. So this is really how it breaks down. It's actually about like a 50-50 split. So 12 local public health authorities decided to hold the contract and subcontract for SBHC funding. 11 decided to decline, and so that's when we contract directly with the medical sponsor. And then 2 decided to hold on to some of the contracts and then subcontract for others. So interesting that it didn't change, but thought we'd share that back with you all. And then importantly, another piece on the funding conversation is, so we have put forward amendments for your funding for the next biennium. So that includes your base funding, the mental health expansion grant funding, which Micah will talk about soon. And then if you're a new site, so planning site, or have newly applied for certification, we have put those amendments forward. And hopefully you shouldn't see a disruption in funding. If you receive funding through a grant agreement with the state, there may be a slight disruption because we are contracting, because of COVID apparently has like really gummed up our contracting process right now. But the amendment's been submitted. Hopefully it's working its way through. So by July, you should get your funding. We will make more amendments for folks who, if anyone decided that they don't want their mental health award or wants part of it. It doesn't sound like anybody has said that, but if you do, we would make an amendment to kind of pull back some of that funding. And then Micah will talk about our youth-led grant awards. We will be making amendments for those. Any questions on those pieces? Okay, I'm going to turn it over to Micah, who was not mentioned, but is our school mental health specialist and is great, along with Kwong, who's our admin specialist.
Thanks, Kate. Hey, everyone. So just real quick, I think most of you have probably seen the emails or emailed with me directly or been on one of our Q&A calls. But so with the flat funding and all of everything that's happening this year, we sort of moved forward with awarding the same amount for next biennium as we did the previous biennium. So that's all captured in the spreadsheet that was sent out to folks. And just to like really reemphasize for people who called into the calls just to ask this question, it really is an opt-out question, an opt-out process this year. So the only reason you need to do anything is if you don't want the money. I'll follow up with people in the fall to sort of, you know, touch base around where money's going to and if it moved to a different site. And then the other sort of big adjustment that we made is that in addition to being FTE for QMHPs, the mental health expansion capacity money can also be used for QMHAs in order to help get folks in the program if people are having a hard time with staffing and hiring. And then I think the next one, Kate. And then this last one, so in addition to the capacity funding, we have what has usually been held for youth advisory councils or youth action councils or YAC funding. Technically, the name for that portion of the funding is youth-led projects. It's usually only been open to sites that had applied in previous biennium. biennia. This time we're opening up to all the sites for competitive application. We're also just giving a little bit more wiggle room, and that if people don't just want to do youth action councils, but they have other ideas for youth engagement work, we're sort of open to that. And as part of that, we're also removing what used to be a big component was youth participatory action research, and we had a lot of technical assistance and support from Matchstick, one of our contractors, around that. And while YPAR is still a youth engagement strategy that we would welcome and be supportive of, it is no longer a grant requirement. Applications for that are due May 31st, and I will drop my email address directly into the chat, so if folks have any questions, they can just reach out to me directly about mental health expansion grant capacity and the youth-led projects.
Great, thank you, Micah. Okay, so we are going to pivot again to talk about what you've all been waiting for, but so what will certification look like next school year? And so I'm going to talk about the policy survey that we sent out, and thank you to everybody for your quick responses to the survey questions, and just share what we heard from you all about what you are thinking your operations will look like. So this was a survey. We asked about what your plans are for summer, what you will be doing for the rest of this school year, and then what your plan is for the upcoming school year. And our plan was to use this information to decide, like, what will our policies be around certification next year. So what we heard from you all, and I'm sure this is not surprising, is that the situation is constantly shifting. There are announcements from the governor, there are changes in COVID case rates, and so that's making it difficult for you all to plan for 2022 school year. And so everything we're kind of taking with a grain of salt, and you're just projecting on your best guess. However, most of you, the vast majority of sites, said that you are planning to return to kind of quote unquote normal operations this upcoming school year. We heard loud and clear, and I'll share in a couple slides what we heard from folks, but it sounds like many of you are planning on implementing telehealth in some form next school year, continuing to implement telehealth in some form, which was really interesting. And there are some pros and cons to exploring those models. And then we also heard from many of you that there have been challenges related to staff turnover due to COVID and lots of other things going on. So we had asked about people anticipating being able to meet our standards. And so almost everyone, I think everyone said that they could meet like our billing and administrative requirements. And the ones that we had a few people indicate that they may not be able to meet were related to the minimum requirements around days per week that the clinic is open, and then the minimum requirements that we have for on-site staffing hours. But overall, most people said that they were on track to meet those requirements. And so I mentioned we asked some questions about telehealth, and we asked about two specific models. So the first model would be a model in which the student is off-site. So that could be at their home, that could be in a car, it could be somewhere, just not in the school or in the school-based health center. But the provider is in the school-based health center. And so we asked how many of you would be looking at different models that kind of followed this structure. And so we have 78 school-based health centers, and a large number of you, a large percentage of you are planning on implementing this model. So you can see 69 are looking at primary care, having a primary care model where the providers at the SBHC. 73 have a behavioral health provider at the SBHC and the student is located somewhere else. And then 67, we're going to be doing both primary care and behavioral health, and 75 would be doing primary care or behavioral health. So really interesting to see kind of how this telehealth is kind of becoming institutionalized in your school-based health centers. And then the other model that we asked about is a model in which both the student and the provider are off-site. So maybe the student, again, is at home and the provider is maybe at home or at a main clinic if there's another clinic off-site. Fewer SBHCs are going to be doing this model than the other one, but still a pretty big number of folks are considering doing this. So you can kind of see we have it broke out similarly with primary care, behavioral health, primary care or behavioral health, or primary care and behavioral health in this slide. I'm going to turn it over to Karen, Rebecca, and Loretta to talk about, okay, so we got this information from the field, and then what else did we take into consideration as we are drafting our policy decisions for next school year?
Hi, this is Karen. So what is the plan for certification standards? We have to take into consideration two assumptions, we feel. One assumption we're going to make is that schools will be open in the fall for in-person learning. And the second assumption that is that if the school is open, then our program would be expecting that the school-based health center be open for in-person services. Another thing that we're looking at as we've made a decision about what the certification standards will look like is what is best practice out there. So the AAP has released guidance about well care and COVID-19. They say that well care should occur in person when possible. Well care should be provided consistent with Bright Futures, and that there's a certain number of things that should always be in person, never telehealth. And the in-person things should always be the initial first newborn visit, any sort of comprehensive physical exam, things like lab tests, screenings for hearing, vision, and oral health, fluoride varnish, and immunizations. The AAP has released guidance about best practice around sick care. I like the second bullet point saying that providers should use interim and updated guidance around COVID-19 to improve provider confidence and the ability to provide care for the same variety of visits provided prior to the public health emergency. Best practice around telehealth and COVID-19, the AAP also has released guidance. Says that telemedicine should not be used as a replacement for in-person care when a more detailed physical exam or intervention is necessary. And this telehealth guidance mainly refers to primary care, physical health care, and not strictly mental health providers. Telehealth visits are a matrix of care options available to provide the right care in the right place at the right time. Telehealth should be based on a medical condition, preferences of a patient, family, and provider, and resources available. And telehealth, if it's being supported by a practice, should always be followed by a timely in-person visit. And then there's best practice also released around safe schools, saying that if you have on-site school services, such as a school-based health center, it should complement a pediatric medical home and provide not only acute care, but chronic care and preventative care. And that if you have a plan for a school-based health center, regardless of remote learning or in-person learning, school-based health centers should be maintained. Okay, so drum roll. Beginning next school year, we've decided that we are going to return to upholding the certification standards for compliance by requiring waivers if you're not meeting standards. And so we've taken into consideration the policy survey, the governor's request to have in-person learning, and then the best practice guidance. So as a reminder, since we haven't done it for over a year and a half, we won't have done it for 2 years once we get to next fall. If any school-based health center needs to notify our program within 20 calendar days of any change that brings a school-based health center out of compliance. And waivers are put into the operational profile, and the waivers must include an explanation of what's going on, a plan, and the date for meeting compliance. And so we're going to require waivers beginning October 1st. This aligns with the due date for when you need to fill out the operational profile in the fall. So as a reminder, examples of waivers would be if you're not able to be open the minimum 3 days a week, not open at least 15 hours a week, not meeting school-based health center staffing. Things like you can't have availability for same day and scheduled appointments, or if you're not providing some sort of physical health minimum requirement on site, for example, physical exams, acute care, immunizations, things like not billing. And then this brings us to site visits. So we know that last year site visits have been virtual. We're striving for next school year for site visits to be in person. And for that, we consider that we need kind of like 3 green lights to move ahead for in-person site visits. So the first green light we feel we've completed, and that is that our team and your teams have been eligible and have had access to COVID-19 vaccine. The second light we kind of feel is yellow, and that's kind of that one-on-one relationship with each other in talking to the medical sponsor and just making sure that site visits are going to be okay on site at your specific school-based health center. And then the third light we kind of feel is red right now, which is that as employees, we're not allowed to travel yet. And then also the ODE's Ready Schools, Safe Learners guidance says that you can have essential visitors on site, but you cannot have non-essential visitors on site at school. And so I've sent an email to ODE to clarify where Rebecca, Micah, anyone on our team falls into that visitation, and they haven't responded yet. So I'm sure that guidance will either we'll wait for a response, or that guidance will obviously change sometime between now and the fall anyways. And I'll pass it to Loretta.
Hi, everybody. So I want to be clear when I'm talking through here that you understand that we're talking about data-related requirements for the future service year, 21-22. So school-based health centers will continue to be required to submit encounter data as usual for on-site clients and visits. We'll have our standard deadlines of January 15th and July 15th. For sites that aren't on OCHN. And telehealth encounter data, we're still trying to figure out what we'll be doing, what we'll be expecting from you all to submit for visits next year that are telehealth. Part of our determination is what will we count as a school-based health center visit if the provider and the student are physically off-site. Now, I know what you all submitted to me at the end of last year, as well as for mid-year, included on-site and telehealth visits, and I want you to continue to do that for this current service year. So for that year-end visit report due on July 15th, I need you to submit everything that you submitted similar to that mid-year data report. So that's all on-site and telehealth visits. We're going to, like Kate was saying, after the policy survey, we really dove into your responses, and we've been doing a lot of planning. Every 2 weeks we've been meeting to try to come up with some guidance, and we're still trying to figure out this one piece about telehealth visits for next year. Our goal is really to have something. It was going to be by the end of May, and I'm giving us until sometime in June to come out with this guidance because I want to be sure that we've really thought it through. And it's never an easy decision when you're trying to submit those data reports to us. So the next slide. So we're going back to the standard deadline of October 1st for the operational profile. Last year it was December 1st. But we're going to go back to October 1st, and we're going to go back to holding an operational profile training that I'll be doing sometime the end of August, beginning of September. And so that training is for anybody. It's not just for new coordinators. Encourage folks to try to attend that, and that information will be forthcoming over the next month or two in all likelihood. So here's KPMs, and again, this is for 21-22. For this current service year, you'll need to submit all of your the results of your audits October 1st, 2021. But for next year, this is what I want you to understand, there are going to be no required benchmarks again. All sites have to go back to auditing the 2 required core KPMs, well visit and health assessment. And then sites will also go back to choosing 1 optional KPM, but it's going to be that larger list, which includes additional immunization measures and some of the other ones. I'll be updating the guidance documents that we post on our website, and I'll send out an email to everybody when that's been done. And we are making changes to the operational profile for the optional measure KPM selection. So please don't go into the operational profile until you hear from me. And again, by the end of June, we should have the OP updated. And so the satisfaction surveys, we're still working on those and trying to come up with guidance and more information for you all about the standard iPad survey. And then we're also going to, we're considering a pilot telehealth satisfaction survey. I know some folks had reached out to me really wanting to collect satisfaction information from telehealth services, and so we know that that's important. I want you to please consider attending a listening session on June 3rd at 10 a.m. if you want to be part of the discussion about a pilot survey and provide your feedback, and an email will be going out very shortly. And that's it for data.
That's it for our updates. I know that's a lot. Thank you, Karen and Loretta, and Micah and everyone for those updates. I want to hold a little bit of space for time or for questions if people have them. And I don't know, in the meantime, feel free to unmute or type in the box. I'm not sure if everybody saw, there was a question in the chat about if a waiver could be submitted for clinic closures or telehealth due to COVID outbreaks. And the answer is yes. However, it would have to be, you would only need to submit it if 20 days had elapsed for that clinic closure. Any other questions about our requirements for next year?
So just make sure I understand, no benchmark then for 2021, 2022? Just do our best to get as much kids in, okay?
Yep, and you will still need to submit your audits for this current service year. So October 1st, you'll be submitting those.
Okay.
Kate, can I take a minute just to do a quick update on something that is not certification related, but just so as the field's aware? Because the COVID vaccine obviously is now eligible, as you all know, for the 12 and over, the state is trying to do a lot of work around campaign and marketing and support to the field. So Karen and I have been in conversations with the state communications team around COVID response, and then those in charge of getting the vaccine out. And so one of the pieces is really supporting you all to become COVID vaccine providers if you're interested or able to do it. And also a lot of support, and we are trying to do a lot of advocacy around having some strong minor rights, minor consent forms and FAQs out to support both sides of parents knowing what the minor rights are, and also so minors know what their rights are. So I think in the next week, you may see a really quick survey or some questions go out to the field on if you are holding clinics for vaccine, if you want the state to help you promote. They have a lot of, they have a handful of contracts with teams that have different presence, so social media presence, and we're trying to really support them on their marketing communication. So if you all, if you see something come out from us, if you're able to respond, and we're also just trying to track what clinics are happening, so people are asked, and then what support you may need from us.
So Rosalind, the JAJ is what we're talking about, right? The 12 and up?
Nope, it would be the Pfizer at this point.
Oh, for the 12 and up?
Yep.
So no requirement on the special fridge for that vaccine, right?
I think there's some nuances. Karen, do you want to answer?
Yeah, we know that 28 of 78 school-based health centers are already signed up as pandemic providers to give vaccine. The state's really encouraging people to start ordering Pfizer vaccine on the hub and spoke model. So if you see immunization emails, there's people across Oregon that have ultra cold storage for Pfizer vaccine, and they want people to start ordering small quantities, and then eventually just order and store in your own conventional freezer. I think the current recommendation is you can have it in your conventional freezer for 2 weeks and then 5 days in your fridge. But they know that eventually and soon the recommendation is going to change, and you're just conventional freezer in your clinic can store Pfizer for 30 days. That just hasn't been announced yet by the CDC, but they're looking at longer storage in conventional freezers. So they're really looking at school-based health centers as being a point of access for teens for when kids just come in the clinic and need a shot. And they're trying to move clinics, not necessarily away right now, but building the infrastructure so that just clinics can give vaccine ongoing over the months for people that change their mind about getting vaccine in the fall, etc., age in, whatever.
Yeah, I think some clarity around storage and you know, those kinds of things, we need to be very careful, because 20 days is, it's, you know, if you don't, if you can use them in 20 days, then we got those vaccines.
Yeah.
And 20 days, not a very long time at school-based, you know?
Yeah, so we're collecting, we're trying to get us the resources together, and specifically that will be helpful to you all as school-based health centers,
Yeah.
and send that out, and then try to collect some information on what you all are planning to do so we can get some attention from the state to help support where it's needed too. So just keep an eye out for that. Hopefully we'll get something out in the next week.
Thank you.
Yep.
Thanks, everyone. And just want to be conscious of time. I know to answer one of the questions that was in the chat, Karen and Rosalind have been coordinating with our crew leadership around vaccination and local public health and SBHC. So as I said, they'll send out more information about that. Okay, I'm going to pivot again and hand things over to Maureen from the School-Based Health Alliance, who's going to share some updates from them.
Thanks, Kate. Next slide, please. So this is our team. Just wanted you to see their faces since we never get to see each other in person anymore. I'm not going to go through the names, but you'll hear from people. Next slide. So wanted to just talk about policy stuff again. Rosalind mentioned House Bill 2591. That's our bill this year. And those are the three things it does. Increases the school health planning grants, always good. Adds mobile school health models, which I think some of you all have explored before, but maybe you haven't because you knew that you wouldn't be able to get certified. So this is just something we have wanted to explore since it's just not feasible for every school to have a school-based health center. And then the same with the telehealth pilots. So the telehealth is a little bit more than just doing telehealth. It's specifically between an SBHC and a school nurse, presumably with the idea that the school nurse in the originating site is going to have the kind of equipment that you would need in order to be able to provide a thorough exam that the SBHC provider could then view and determine if the student needed to be seen further at the clinic, or if some kind of telehealth care could be provided right then. And then I wanted to bring up House Bill 2368 again, which is the expansion and funding support for trauma-informed schools. Next slide, please. Nationally, I've already mentioned the reauth authorization passed, so there's now an SBHC program that's national. The $5 million for FQHC sponsored SBHCs has the applications have been received. They've had around 300 applications, only 25 are going to be approved. So wishing you all luck to whoever here applied. And I don't know if you've heard yet, but I just heard that the announcements should be sometime around August. So we would love to know if you get one and what you're doing with it if you do. But the fact that there were so many applications and very few are getting awarded is actually kind of useful for advocacy purposes, because we can say, look at the need, and it wasn't even close to being met. So we're still advocating for more money, we being our organization, national and other state affiliates. The amount is being debated, but it's looking a little bit different than anticipated, where the way it works with HRSA for some reason is there have to be two funding pools. So if there is federal money now, it will be for either FQHCs or non-FQHCs. There isn't going to be a combined pool. It's the way that the HRSA, it's a way the original HRSA FQHC policies were written. If they moved them into the SBHC program, you wouldn't be allowed to get the FQHC wraparound. So it has to be two pots. That was probably more info than people needed, but in case you were wondering. And then also, National's been advocating and believes that the infrastructure bill should include language that says that education can use funds for SBHCs. So if there are capital projects that need to happen, or if there's been a determination that the community wants an SBHC, but there hasn't been any action yet, the infrastructure bill may be able to support that. And similarly, there may be some community school grants coming out in the next year for comprehensive community schools, and those have as a kind of a fundamental piece of them, they are supposed to have school-based health centers. So that's something else to pay attention to and talk to school partners about. Next slide, please. I wanted to let you know, even though this is done, that we had a virtual youth gathering. So thanks to those of you that recruited youth for it. We had about 70 participants, which honestly, I think was pretty darn good for this time of year. And they were broken out into caucus affinity group. So there were racial groups, disability, and things like that, so that we could hear if people were experiencing school-based health centers, or if they don't have them, if they were having different kind of school health experiences that are different based on those racial, gender, etc. groups. So we will be creating a report out of that, and then we'll be doing a webinar sometime in the fall, just sharing what we've heard. Next slide, please. I wanted to bring up Basecamp again. I mentioned this in the last meeting that we were going to do it. Now we have. Some people have signed up. I'd say it's a relatively small number compared to the size of the group here. And obviously this is totally optional, but I think it would be really great to have a place to share information. So those, as you just almost started having a conversation about vaccines, but there was no time here, that could be taken to Basecamp and people could start sharing what they're doing and what that looks like. So just something to let you know about. Just email this admin@osbha.org email address, and we will get you signed up and you can start communicating right away. Next slide. I always need to talk about membership. So thanks to those of you who paid your membership dues. If you still haven't, we'll probably send one more invoice, and yeah, we appreciate payment. It's really the only thing that allows us to do our policy work. Our grants don't allow us to do policy work, so these unrestricted membership dollars are what lets us get that done. Next slide. So here's how you get in touch and follow us. If you want to sign up for our website, you can, for our newsletter, you can just go to our website and there's a little button. Elizabeth says, I love that you have a soundtrack. That would be my daughter's. I did not know you all could hear that, but I'm glad that it was fun. All right, well, thanks everyone. That's all I have. Let me know if you have questions.
Any questions for Maureen? Maureen, maybe you can leave your soundtrack music on for our break time. So we have like 5 minutes for break. It's a little shorter than we were planning, but I want to restart our conversation at 2:10, so we have time to hear from all of the folks in the field. Feel free to turn your camera off, turn up your music, meet us back here. If you have questions or you want to chat with us, some of us I think might hang around. Feel free to do that in the chat box. But we'll see you all at 2:10.
Well, she stopped it right then. Right after I got done talking.
That's funny. I don't know if Elise is still on, but I don't know if she's referring to data or certification. So I guess
She messaged me that Loretta followed up with her.
Oh, that's what I thought, because it was right after Loretta's. So I figured it was data, and I would wait.
Yeah, it was data.
Okay, great. Thanks, Loretta.
Hey team, can I just check my volume quick? Because it cut out a little bit ago.
It sounds good.
Yeah.
Hi, Brooke.
So good to see all of you. I just love it.
Excellent.
Okay, thank you.
Good.
I appreciate it.
Rebecca, how was the conference? Did you do the Adolescent Health Initiative conference?
Sort of. I had so much trouble with the technology. I don't know, did anybody else do it? Most of it I think I have to wait for and hear and listen to the recording.
Was it their technology or was it your?
Theirs, yeah. Yeah. All right, it's 2:10. We'll talk about later.
Okay.
Rebecca's
Somebody's in
strictly
a hurry.
business.
Okay. Okay, hi everybody. I am Rebecca Jacobs. I'm one of the public health nurses here. And so we get feedback, lots of feedback about wanting to hear what's happening in the field. So we thought we'd try this, and thanks so much to the people that have stepped up and are going to talk a little bit about their sites. And I don't want to take any more time except to say, for questions, go ahead and put them in the chat, and if time allows, we'll get to them. Otherwise, we will make sure that those questions get answered. So first, we have Ceci Rogue from Jackson County, and he has school-based health centers down there. For Rogue, go ahead.
Okay, can you hear me okay?
Yeah.
Great. So yeah, Rebecca asked me to talk a little bit about one of the work we're doing around screening for social determinants of health in our school-based health centers. So I guess I would say that Rogue is an FQHC here in Jackson County. And I've been working involved with school-based for over 20 years. I'm still learning and adapting and enjoying the mission of what school-based health center stands for. So we are present in 4 different school districts with a couple of very remote sites, which is always presents some challenges of its own, right? And where the needs are greater. And like you all, I think COVID has been a tricky thing to navigate as it affected all of us. And when I say all of us, I mean not only the schools or the students and their families, but also the teachers tremendously. And of course, our own school-based health center staff has been affected by it. So what I want to just share briefly is a new workflow that we have been developing when we got hit with the closure starting back in March 13, over a year now of a last school year. So, and since then, for school districts here, it has been touch and go, right? We're opening, oh yes, no, just kidding, we're not, we're closing again. So one of our school districts opened for the very first time, actually, not until April 26th in Ashland. So this has been, when you have April 26th be your first day of school, is it's hard, right? And all the others started January 25th. So, and as most of you have experienced, and I'm sure as school-based health centers are typically at the Title I schools, life got very hard, very stressful, very fast. So in January, we contemplated bringing into the schools what was already part of rural community health, culture, and values, and part of our mission, you know, so our continuing engagement and work with community partners as well. So what we have done in these first initial stages of this work is considered how the social determinants of health are affecting our students in light of what COVID has brought, of course, to our attention with the distance learning, you know, with the fires in the region, with increased unemployment in the area, and other stressors outside of what we are used to, which the medical and the behavioral health needs at our school-based health centers. So around February, shortly after school came back to in-person learning, again, like I said, it was not until January 25th for our school districts here in Southern Oregon, we decided that it might be helpful to screen the students to see what's going on. At first, the ones, of course, that we were receiving referrals for behavioral health already. So we expanded that, we augmented that referral process at our schools to include those social determinants of health, as well as, you know, what we typically do with referral for behavioral mental health therapy. So we are using what is already in place in EPIC, actually, as our first step in the screening process. So when we are doing the health assessment screening, we jump right into the social determinants of health as well within the visit. So if the social determinants of health are identified during that visit, then we have brought into the picture, and I think that was a very bold, I think, move on RCH to bring what we're calling the school care coordinators. So these and we have hired 2 of them. They are in fact just community health workers. They are community health workers providing support for the schools. So they can perform home visits and do any outreach needed to help support the families with their needs. You know, there are identified in our referral process as items that would qualify for the social determinants of health. So their office is at the main clinic, but they are 100% mobile. So as they go, they can go anywhere depending what the need is. They can perform in-home visits, and they're fully bilingual, which is helpful to our community here. So we are implementing phases of this new workflow, obviously, and we're still ironing out some of the kinks with it, and we will hopefully use what we learned in the past few months to help us improve the process in the fall. So the takeaway really is, you know, adding the school care coordinators to help with that. We develop a school health referral form to include the social determinants, not only behavioral health referrals. And we're doing that through the job form. So any teacher, anywhere, any school, whether we have school-based health center there or not, they can make a referral for our services. And then with that, we close that loop referrals, and, you know, as we engage community assistance for some of these social determinants and other things. So we are able to report to the school district, and we've done that. We're doing that at the end of each month, and we had our first one that we send it out, which is, I think it's a good visual for the schools to kind of see what we're doing and, you know, what services we are providing. So that's basically it.
Thank you. That's so great. Thanks.
Yeah.
I know this is going to go. I know that you could talk a lot more about this. So
yes, and we're using EPIC, right, to the vision. They have the social determinants, and we go to that call there and just tab on that, and we start to, you know, like I said, that we should make it better, but for now we're using the tools that are already available to us and just implementing that process with the assistance of the school health coordinators. So a more comprehensive help, which is what a lot of the school districts are in need of, right? Especially here with everything that we have experienced in the last year. So
yeah, thank you.
Thank you for the opportunity.
Yeah, I hope that there's another time where we can extend these, so because I know that there's so much more. But thank you so much, and let's go on to our next. Okay, so Multnomah County, we have Alex Lowell, and she's going to talk about health assessment improvements. Out there.
Good afternoon, everyone. You made a nice slide for me there, Rebecca. I like that. Okay, so in this short period, I want to talk about some quality improvement work we did for our health assessment. And this was really built upon just a few members of our clinical team not feeling content with our health assessment, the information that was being captured, and also the way some of the questions were worded. And so there was some opportunity there for improvements. I'm going to highlight the main sort of most substantive changes that were made. These changes, we were able to address some issues around racism and other types of discrimination, and also dig a little deeper and kind of update questions that we needed to expand answers, and sort of probes for people to think about the behavior we were asking about. I think the really great thing about this quality improvement project was that it was a partnership with our YAC. And we were able to, it was in a virtual setting, it was done last fall. And so we were able to recruit a handful of YAC members to participate and to basically do a focus group around our health assessment and to talk with them about the questions that we had, and also to hear about maybe some of the areas that they thought were important that we would include in the health assessment, and to improve the way we ask the questions. So it was really nice to pull from the youth, and it was just exactly the kind of sort of student health center youth engagement partnership that we want to promote with our YAC work too. So if you go to the next slide, and I'll also say the youth, it was about a 45-minute focus group, and the youth got an incentive to participate. And they were really interested in participating and giving feedback and helping the Student Health Center. I have our old version and a little snapshot of our newer version down below with the highlights. This around the area of physical activity, nutrition, and activity. We changed the wording, how happy are you with your weight, to move away from that focus on weight and ask how happy are you with your appearance. And then around the restricting and controlling calories, we wanted to add skipping meals, restricting calories, binging frequently, or fasting, because we had not included all of those pieces into that issue. If you go to the next slide, please. The emotional well-being, this is where we put the question, and this was really the big push of this initial quality improvement project, was around addressing the effects and impact of racism. And when we talked with the youth, they really wanted to broaden that and include other types of discrimination. So after a lot of conversation, we landed on, have you been bothered, made to feel less than or left out due to your race, ethnicity, gender identity, sexual orientation, religion, learning difference, or disability? So a lot of things listed there, but it really captures many elements. And then we also added some questions around social media. So what do you use social media for? And then, is social media causing stress, decreased self-esteem, worry, or sadness? For risk reduction, we got more specific around some of the ways people can use these drugs. So we added weed, oil, hash, hash by smoking, vaping, or in food, or synthetic marijuana like K2 and spice. So just got a little more on top of the access. And then we got more specific around other types of drugs that people can use to get high. So like illegal drugs, prescription, over-the-counter medications, anything that you can sniff, puff, or vape. Around safety and injury, we got more specific with the definition, or getting them to be thinking about are they getting bullied, harassed, or picked on, and we got specific with cyber, verbal, or physical. And then around have you ever been in a relationship where someone threatened you, hurt you, or made you feel disconnected from family and friends? And then at the very end, we have some open questions that I didn't include here that they could answer, that identified some positive supports that are important to identify, and they're open-ended questions. And that's all. Thank you.
Thank you so much. That was really good. And I love that you had a youth focus group there to help you with that. That's awesome. Okay, next slide. All right, so Benson School-Based Health Center here in Multnomah County, Dr. Nancy Zink and Caroline Bleckman, I believe are going to talk about some of the equity work they're doing.
Hey everyone. Yeah, I'm Caroline Bleckman. I'm a licensed clinical social worker and kind of the overall coordinator, whereas Dr. Zink, Nancy, is our coordinator and medical director, and we all work closely together. I would say I'm coming at this share out with a lot of humility and more questions than answers, but let me summarize what we've let me summarize what we've done around health equity and kind of what we dream of doing. And then I would love to see questions in the chat and questions and suggestions and that kind of thing. So I don't have a ton of concrete information, but I can sum it up and I welcome people's thoughts. So just, I was like, oh, what's the definition of health equity? And Robert Wood Johnson says it's, that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And then I, Caroline, would editorialize that, and I would specifically call out racism when we talk about discrimination, and I would editorialize that, school-based health centers are at the intersection of two fundamentally racist institutions, education and healthcare. So there's a lot of room for improvement and a lot of room for good work. And so I thought I wish I had the meme, like, how it started, how it's going. That's how I would sum up. We've been open for 5 years. And, how our health equity work started was arguably starting the Wellness Center was a move toward health equity. Benson's not a neighborhood school, and understandably so, Multnomah County was putting its resources in other parts of the city, which I've worked in East County, that made absolute sense to me. And yet, since we're not a neighborhood school and we serve such a racially and economically diverse group of students, most of whom qualify for free and reduced lunch, for them to see a medical provider, assuming they have a primary care doctor provider, could easily take the student out of school for a day due to distance, and most of our students take TriMet. So having this was a move towards equity. And I also want to credit our state program office and policies that have allowed access to these clinics in the first place, and to the state of Oregon for expanding OHP to all who qualify financially regardless of immigration status up to age 19. So those, and then furthermore, our state's laws around being able to consent to health care and reproductive health, especially reproductive health care at any age, and self-consenting to medical care at 15 and mental health care at 14. Last year, we were part of a project with the American Academy of Pediatrics, and we were on a lot of Zoom calls with folks from clinics across the country. And so many of their issues around access to reproductive health were like kind of snoring a little bit. It's like, no, we're doing that. No, that's not a barrier. No, that's not a barrier in Oregon. That's not a barrier in Oregon. We're already doing that in Oregon. So I felt pretty proud of us. So that's, kind of how it started. Oh, and then just the other thing is that I jokingly call us a food court model. We are 4 co-located entities beholden to our respective organizations' policies and practices regarding equity, including racial equity in healthcare and education. So how it's going. This is where the humility comes in. This is just really mine and Nancy's opinion. We are 2 white cisgendered women. So we're coming from that positionality. And I would say one thing we always need more of is more robust and ongoing student voice. So from our perspective, our staff care about health equity, including centering race as a barrier, and we see it as a priority. Some of our ongoing and targeted endeavors include, some clear feedback we've received from students is we want more staff in the Wellness Center who look like us. In other words, are people of color. And so as there has been turnover in the Wellness Center, we've really challenged and encouraged and pushed on our organizations to bring in BIPOC staff. I know, for example, myself, I've kind of drawn a line as far as taking interns that, in the interest of having more diversity in our clinic, I really want to prioritize recruiting and retaining and providing a supportive learning space for students of color for social work internships. Some endeavors as a team have been signage in our clinic, and I'm sure a lot of y'all are doing this, social media and signs that just kind of signify safety and inclusion. One example is during our tech show, Riva, our former medical assistant, did this wonderful art project where students could do canvas artwork. I wish I had some images of it. And, one sign that we made that went above our scale was, your weight is not your worth, for example, for when students are weighed. We're willing to help students with built-in barriers. One built-in barrier is that in order to first be seen as a patient with OHSU, it does involve registering with OHSU, often with a phone call. OHSU has been able to find some flexibility with our medical assistant so that our medical assistant can help with that and register them on the spot. And we're all willing to sit down with students and make the call. We're aware that can feel particularly scary to students who are from mixed status families or are undocumented, and we just do our best to provide some reassurance around that. And we see these barriers as equity issues. I feel comfortable speaking for our team. I think that we have a respect for sort of the healthy level of distrust from students with marginalized identities. We see that as adaptive and as a survival skill, and we also see the stress of having to come from a place of mistrust. This stress threatens their health. So let's see, something that we were trying to do before the pandemic was we used our OHA grant from a couple years ago to work with Trauma Informed Oregon and the Equi Institute to provide some ongoing training to our team around creating a trauma-informed space and also providing trans-affirming care to our students. So it had to shut down abruptly because of the pandemic, and that's all I really know how to say, but it's something we're interested in doing. We've definitely done some student-focused groups, and we are using our money from OHA for targeted outreach to students, and then also, so targeted outreach to get feedback from students. So we don't have, when I say we don't have a concrete form and I'm seeing if there are any, 1 minute mornings. So does anyone have any questions about that? Questions or feedback? People are welcome to put in the chat ongoing. I'd love to hear feedback and ideas too about that.
Thank you. That was me. Yeah, 1 minute warning. Sorry.
Yeah. I could talk all day about the Vincent Wellness Center.
No, and also we have your contact information on the slide, and then if anybody wants to put anything in this chat, and hopefully we have time at the end, I'm not sure, but we'll see how it goes to have conversation. So
thank you.
Thank you so much. Okay. Oh, yeah, Bethel Health Center, Cascade Middle School, Brooke Cottle. We have talking about, I think, school integration, some specifics. So.
Sure, you bet. You hear me okay?
Yeah. Yeah.
Great. Okay. So, so my name is Brooke Cottle. I'm the director here at the Bethel Health Center. So our model is we have 11 schools that we serve in our Bethel School District. And that's the way it works. So we work really closely, of course, with our host school, but we're seen as a district-wide school-based health center. So we have a nurse practitioner, And then we have 3 mental health therapists. Not all of them are full-time, of course, but that's sort of the semblance that makes up our team. And so just really quickly, when I was asked to just share a little bit about how we've tried to really integrate with our school and our community, there were 3 things I just wanted to share, and I know time's short. But first of all, we've been really heavily involved with the vaccine clinics in our area. And so when we're in Lane County, down in the Eugene area, and so as soon as the vaccines hit, it became clear really quickly that it was like an all hands on deck kind of a situation. And so we quickly staffed up clinic at our high school. They let us take over the cafeteria, and that's where we've been hosting clinics since January. And it started really with the educators. The county just shared that they didn't have the capacity to really get into all of these educators, and as the vaccines were just arriving. And so we just, that's something we do, of course, as you all know, and like, oh, we know vaccines, we know how to do this, we know how to make this work. And so, so that's what we did. And we have worked really closely with our Eugene Springfield Fire Department that's helped us. Our school nurses have been incredible. But as school has started, then of course they have been really busy with these kids back in school. And then our Bethel Health Center team, we also had a few retired nurses from our district who came back to help. And it's just really been a team effort. So that's what we're doing. We've spent, it's been really amazing to support our educators. And then we started, of course, with the 16 plus, and then this week we're doing the 12 and older, but to just provide this center in our community and to really highlight the Bethel Health Center, the work that we do, and the way that we're supporting our community. So that's been amazing. We have, we've administered about 3,400 vaccines, and we're set for about 700 more this week. So it's been intense and really intense, but it's also been a really wonderful way to just be part of that community work that's happening. So just wanted to share a little bit about that. The other area where we've been able to coordinate with our school district and do a lot of work is around mental health. So we've worked closely with our school counselors in terms of their development of their safety plan and their system that they're using for safety planning. We worked closely with the district and have trained our schools on the Columbia Suicide Severity Screening Tool. And that's something that has allowed for a really wonderful partnership where they've looked to our mental health professionals to help guide some of that work. And we've collaborated around what makes the most sense in a school setting, but developed a very clear process on when a student is at risk. First of all, identifying if a student's at risk, and then if they are, what the next steps are. So that's been an opportunity for us to provide that support to our school district, and it's been a really wonderful partnership. We also help lead the Sources of Strength program in our district. So a lot of the suicide prevention work, the SAVE trainings that are coming out of Oregon right now, where they really are talking about suicide prevention, using the Columbia and integrating Sources of Strength. It's like, oh yeah, like right up the alley of what we have found that has worked really well. So a little bit about that. And then the other thing, just the last thing I wanted to share in closing was that, as our medical care, those numbers dipped a little bit, of course, once the pandemic started, and we moved really swiftly to telehealth for all of our services. But as we, looked at, okay, how can we, what's the best opportunity and way for us to support our community right now? And our school-based health center has also served as our employee wellness clinic. So that's the way our system has been set up. But we realized that as families were navigating the pandemic and all of the hardships that come with that, that really an opportunity to serve our community would be to open up our appointments to family members as well. So we worked with our school board and received the okay from them. And that has been amazing. As we know, that's the best way that we can support families, is so often from these parents and students. So yeah, we've even had a couple of students who, you know, really weren't interested in counseling, but clearly they were they're really struggling, just wouldn't engage. And so we started working with parents as a way to support them as they support their student, and to see that funnel down has been pretty amazing. So those are just three that I wanted to highlight in terms of, you know, when we work with schools and trying to support our community. Bethel's a pretty tight-knit area on this northwestern side of Eugene. And so it's been really great to have the opportunity to just share the work that we do and to support our community. So that's all I got.
Thank you so much, Brooke. And Karen put in the chat about all the media that your vaccine clinics have been getting. There's been lots of articles about all the work that you're doing down there. So,
well, it's been a huge team effort for sure. It takes a lot of people to staff those things. Thanks.
Okay. Kate, where are you? Oh, there we go. Rebecca, are you out there?
I am here. My screen says that I'm Elise, but I assure you my name is Rebecca, and I am the nurse manager for La Clinica School-Based Health Center in Jackson County down in Southern Oregon. And when Rebecca asked us what we've been doing through the pandemic, if we could share a little bit about that, there's just so much that we've been doing. And part of that is because of the model that we have. So our school-based health centers have a nurse, an RN, 5 days per week. And that's in addition to our provider that we have 2 days a week and our mental health therapist that we have 5 days a week. So when the pandemic hit and all of the schools shut down completely, La Clinica opened a respiratory triage clinic to take all of the potentially contagious community members and have all of their visits in one area to reduce spread. And what we discovered during that period of time is that the nurses could be a huge asset here. So our nurses, while schools were closed, were able to pivot and move into our respiratory triage clinic temporarily and provide phone triage support. And that continued through the fall when a number of other things happened. Our cases began to spike again in the late summer, early fall. So when the new school year opened, we were completely virtual. We had limited in-person instruction, only 2 days per week. So we had our providers on site. And then September 8th, we had a fire that devastated 4 towns here in Southern Oregon and destroyed thousands of homes. And our nurses, as well as our therapists, teamed up with our mobile health center, and we went to the expo where a lot of these community members were being housed without any shelter at the moment. And we provided care there for, I want to say more than a month while people were being temporarily housed. And then through all of that, with our numbers spiking, we realized that we really needed to do some work in flattening the curve, as they say. So we focused our attention on flu clinics. Oh, and I skipped the other part. Back in April, we were one of the first in the area to provide some vaccine clinics, and these were specifically focused on pediatric vaccines. We noticed that we were having less and less well-child checks, and I was reading the news about how the rates were dropping, not only just locally in Oregon, but around the world. So we took action. We were the first to hold some drive-up pediatric vaccine clinics, and they were very successful. We held 3 of them, and we had a better turnout than we had had in most of our in-clinic vaccine clinics. And so that just really drove us into the fall when we were able to have flu clinics. And we vaccinated even more than we had done at the pediatric clinics, and were able to keep our numbers, hopefully our curve, pretty flat there as much as COVID would allow us to. And then in January, when Moderna came, we then opened a drive-up COVID vaccine clinic. And our nurses helped support this clinic in addition to our primary health centers. So having this nurse model that we have has really helped us in pivoting and moving wherever the need is throughout the changing times of this pandemic. I don't know, and I think that that's all I really wanted to share about it. That was less than 5 minutes.
That's great. Yeah, that's great. And you talked a little bit about the fires, but then you
right.
You talked a little bit about the fires and
the fires was a huge impact in this area. And so us being able to provide medical and mental health support in the expo where these families were being temporarily housed was an amazing experience. And we had a very good response. And our work with the fires continues. There's so much trauma that has happened through the fires, not just from COVID. I mean, we had enough trauma from COVID already, and then the fires on top of that has really put us at a disadvantage down here in Southern Oregon. And our work is going to continue probably for years beyond this point.
Yeah, and I think some school-based health centers are very lucky to have RNs, right? Not all of them have RNs, but the ability to be so flexible and do the sort of non-billable work that you're able to do is great. So thank you for sharing. Okay. So next we have Micah Woodard and Michelle Livingston from the Chemawa Health Clinic, and they have their own slides. So I just thought I'd share here. But
good afternoon, man. We share that first slide with me. I like that.
I will send it to you. You can use it.
Although yeah, that's great.
Health authority off.
Yeah, that must have been from your guys' site visit.
Yes, it was.
I appreciate that. So my name is Micah Woodard. Serve as the Behavioral Health Director here at Chemawa Indian Health Service. We provide comprehensive services to the youth that attend the Chemawa Indian Boarding School. And so I've been here since 2010. We've got Michelle Livingston, who's our Director of Nursing. I'll let you introduce yourself.
Hello, I'm Michelle Livingston, Director of Nursing, and I've been here at the clinic since 2016.
So we typically have upwards of 400 students that come around September and are here until May, usually the third week of May. Incredible diverse tribal representation, usually in a typical school year from grades 9 through 12. We'll have upwards of 400 students representing 70 or more tribes coming from 20 or more different states. So pretty broad diversity. We've been doing universal screening since 2012. And we initially started your typical type screening where depending on incidents and things that are happening. And so we started shifting towards universal screening. We're an ambulatory clinic. So beyond just the students, we also provide healthcare for over 5,000 community members. So we have dental, primary care, pharmacy, lab, and then behavioral health. So we are very fortunate that we are able to offer comprehensive services. The first week of school when kids get here, which is usually the week following Labor Day weekend, is all about screening. Obviously COVID is kind of, this year all of our students have been attending virtually. And with the close of last year, we had to quickly shift to telebehavioral health, which, as you can imagine, working with kids across multiple states, we had to get kind of creative in terms of how we were going to support them and help with care coordination, transition services. Michelle and I both actually, when we had to shut the school down and send kids home, we met in the auditorium with all the students and just went over any questions, concerns, and we did a comprehensive school needs assessment climate survey to kind of assess current student needs before they left home, specifically asking the most consistent contact information if they wanted continued supports and contact over the summer. I was just sharing with Michelle of our students that attended virtually, how those that graduated, 69% were active in our programs. So we just saw that the other day. Obviously, we're not taking credit for their success, but it's always nice to see that we're supporting a high percentage of students that are able to graduate, especially during COVID. We have a very high-risk population, not just on the behavioral health side of things, but we also have a high-risk population for diabetes and other chronic diseases. We do, if you go to the next slide, let's see. Yeah, we cover the wide gamut. We pretty much, we use standard clinical screens like GAD-7, PHQ-9. We use the ASQ for suicide screening and trauma screening. We also do packets with all the students, and we did a lot of outreach during COVID. We weren't able to do our conventional screening this year, so we did extensive universal promotional outreach and talking to kids on the phone and getting feedback on what's working well. We did a lot of tribal outreach partnership in their local tribes, what resources are available. So doing broad care coordination support, developing a care coordination database with different tribal contacts. We really kind of took a lot of this COVID turned the challenges into how can we use this as an opportunity to strengthen our care coordination collaboration at the local tribal level. I'll let Michelle speak to some of the healthcare related screening processes that we do.
Yeah, so obviously not this year because none of the students were on campus, but in previous years and hopefully this coming year, we do comprehensive medical screenings as well. All the students go through optometry and have a vision screen. Anyone needing a full vision appointment gets those immediately. For dental, they all get a dental checkup and a fluoride treatment. And then as far as medical goes, we do health education where we kind of tell them a bunch of health education things, but also how to access the clinic, what kind of things they might want to request a public health nurse visit for, talk to them about access to birth control, STD testing, Plan B, all of those things and how they access those through the clinic. We also tell them about all the different services we provide. And then for the medical screening, we do a health history questionnaire that kind of triages the students into priorities so that we can make sure that children that already have identified chronic healthcare needs get in for a well child visit first, and then stratify the kids based on what we already know about them. We do height, white blood pressure for all the students, do vaccine updates for all of them. We get their vaccine records prior to them arriving at the school. They come in with their application. We do hearing screens on all the kids, and then we do labs. So for a new student, all of them get gonorrhea, chlamydia, HIV, RPR, a lipid panel, and for the females, we do an HCG. For returning students, we don't do the HIV or the lipid panel. And then any student that would like one or that is participating in a sport can get a sports physical through the clinic that first week during student screenings or any time during the year, really, for that matter. And then as far as our screenings and the kind of things that we identified, for instance, the last school year, we identified 20 abnormal hearing screens. 11 of the students ended up being referred, so they come in for a nurse visit. Most of them need ear lavage. After that, we do redo the hear screen, and if they're abnormal again, they get referred out. Let's see, 16 students came without an EpiPen that they needed to get. 58 identified as having asthma. We did group asthma education visits, then got them in one-on-one with a provider so that they could have their asthma worked up properly if it was never actually worked up properly at home, get them the medications that they needed, things like that. 8 identified having diabetes, so we got them in for appointments and made sure they had all the medications that they needed right away. Identified students wanting birth control education and birth control options, get them in with the nurses so that they can be educated on the different options, then get them in with a provider so that we can get them what they need. And then every year we usually identify between 15 and 20 STDs, gonorrhea, chlamydia, of which we get them on a treatment regimen right away. And then this year is kind of exciting because STD screening has typically been sent out. So someone that was tested on Monday will get the results maybe on Friday, and then the kids have the weekend, and we're struggling to get them back in Friday afternoon so that we can get them treated before the weekend. But this year we have a Cepheid that we got in our lab, so we'll be doing all of our testing on site. So this is a big improvement for us.
Yeah, you can go to the next slide. Thank you. Yeah, we're fortunate to do very comprehensive screening. We definitely have statistically, obviously, we have a very at-risk population in our youth. This slide is kind of reflected, mostly is the behavioral health stuff, but along the multi-tiered support, it kind of gives you a sense of where, for several years, our risk categories fall for those we're serving. So we definitely have a higher risk than a typical public school, although I do feel like even most public schools, the estimates of where those fall are under. We've grown quite a bit in our capacity in recent years, and we are actively working to continue to grow that to be more responsive and more comprehensive. Our access model along the multi-tiered support is using what we're calling a positive youth development centered home model, which brings in the whole health perspective and having inclusive access design, so we're not having kids fall through the cracks. So, in a typical school year, we get up to 400 students, but for years before we started doing a lot of this stuff, it was not unusual at all to lose 150 students prior to winter break in December, usually sent home for behavioral health issues. And the first year we went to universal screening, we did more assessments in the first 6 weeks than normally would be done in an entire school year. So, all right, I believe we already spoke to the care coordination stuff. If you want to go to the next slide. Michelle already spoke of that. In that screening process, any of those identified at what would be our high priority or tier 3 level, we immediately schedule them. And for those on the suicide, we'll actually see them in the same day. And we track that through a care coordination system and then just start scheduling appointments, which can be a little bit easier because the students are here in residence. So that's it. Let us know if you have any questions.
Okay, great. Thanks, Micah and Michelle. Kate, this is you closing?
This is me. Yeah, thank you everyone for presenting. As I said at the beginning, it's been so inspiring and amazing to hear about the incredible work you are all doing every day. And this was just a little snippet of it. I feel like we could have spent the whole time hearing from everybody and really digging into the great work that's happening. But we'll have to leave it there. And so just some pieces to wrap up before we end. We are getting ready to release our 2021 School-Based Health Center report, which has our most updated data and information about the work that you all are doing. Karen, correct me if I'm wrong, but I think we're expecting that to come out very soon, and we'll be letting you all know when that's finally available. It was a little delayed this year because of staffing stuff and COVID. Karen, I just saw you on mute. Do you have something you want to say, add?
I was just going to say that what's going to be different about the status report this year is that the OHA is going to do an actual media release when the report gets released. So you should expect to see that highlighted in emails and media stories.
It's awesome. So keep an eye out for that. quickly, Loretta mentioned that we'll be sending out information about the operational profile training that will happen in the fall. We'll also be doing, some of you may remember in the past, we've done SBHC 101 orientations for new staff. That's actually one of the things in the certification requirements is getting new staff oriented to the SBHC model. And so we'll be doing that again, probably as a webinar. So stay tuned for information about that when that comes out. And then finally, the fall coordinators meeting, more information about that to come. You'll hear from the team. It's very likely that we will not be doing an in-person one this year because of all of the things, which makes us sad because we love seeing you all in person. But we'll send out some final, like, definitive information about that in the coming months. So keep an eye out for that. Here's our contact information. It's 3 o'clock. We want to be conscious of time. Thank you all for being here. Thank you again for all the work that you're doing. Please feel free to reach out if you have questions about anything we talked about. And again, slides and a recording will be up on our website. We'll let you know when that's available. Thank you, everybody.
Thank you, Katie.
Bye,
Good to see
everybody.
everybody. Thank you.
Thank you. Bye.
Bye.
Good job, everyone.
Yay.
I'm gonna go.
Bye.
Bye, y'all.
Bye.
Bye, everybody. Thanks. Good job.